Hello, everyone.
Hi.
Hi.
Hi, hello, everyone. I hope everyone is doing well. So we are happy to welcome you once again for our IWC Symposium. And today, thank you everyone for joining. For all the panelists, today we will have two interesting cases. One that will be presented by Logan, a case that was operated by Lorenzo. And the second case from IWC Istanbul by Magomed Dorhoff, a case that was operated by our colleague Bülent Özelik. So as usual, please feel free to ask any question on the chat. Lucian will be my co-moderator today,
Hi,
as usual. Hi. And we will start right now with Logan and Lorenzo case. Logan, if you're ready, please, could you share your screen? Can you switch on your micro, please? How are you doing, Logan? Micro.
Sorry, it's 7 a.m. here, so
How are you doing, Logan?
I'm doing great. Just getting set up here.
I will going to
share my screen.
introduce just Logan. Logan used to be our fellow here in IWC Paris, and she will present very interesting therapeutic option for intracorporeal arthritis, original case. Logan, you can share your screen, please.
Yeah. All right, are you everybody able to see that?
Perfect. You can see your screen, and you can just sometimes stop to ask the panelists and to share the polls about the therapeutic option.
Sure. All right, so for this case, I didn't want to give away the title in case anybody forgot it. We'll talk about it afterwards. But this is a 20-year-old female who's right-hand dominant, and she had an OR for a dynamic SL instability, so an ADCLR in 2021, so 2 years ago. And it was complicated by a post-op infection. So she developed a septic arthritis, and that needed to be treated with an arthroscopic washout and antibiotics. And so she presented for ongoing wrist pain on the same side as her surgery. She's healthy, she has no allergies, medications. And on physical exam, she's tender over her dorsal mid-carpal region. She has reduced flexion extension arc. Compared to her unoperated side, she still has a reduced grip strength 2 years later. She has a negative Watson scaphoid shift test, and there's no clunking. So I was hoping to have a little poll here, but I guess, questions are what, at this point, what investigations would everyone order?
First question, I think we can ask one of our panelists.
Anybody.
Anybody, yes. Anyone would like to?
I mean, this is a post-traumatic case that, complicated by infection that was a few years ago, I assume.
Yeah.
So in this case, I would be thinking, stiffness, I'll be thinking about some arthritis. So I would do a basic investigation of wrist x-rays, PA and lateral view, and I would move on to an MRI scan.
Great. Anyone else?
I think you
wanted only to ask you, Logan, if the patient was treated in the same center or in another center?
It's the same center.
Okay.
Yeah. So we know this patient.
Okay. So you know also from the arthroscopic washout what is the joint condition, right?
Yes. And it's 2 years later, so we're thinking potentially some things may have progressed. So I'll continue to move on. Thank you. We had a CT done, and then this is what we saw. So can anybody comment on what you see? These are only some splits. I would have liked to have the whole scan, but the quality wasn't good enough, so we took out the most important splits.
So do we have Zé, Mort, Fabio, Bülent? Anyone would like to comment the imaging? Maybe Tadeusz, I can see you here.
Yes.
I'm too
Hello.
nervous
So
about
what we see,
my fellow colleagues.
okay, we see sclerosis on the radiocarpal, but this is one thing. The other obvious thing we see, there's a cyst in the capitate. We see that proximal pole of the capitate is deformed on the lateral slice. So this is like first things. When we look on the lateral, the axis seems fine between capitate and lunate. And what we see on the AP slice, there is also some SL widening. Well, probably would be interesting to see other slices to see if it just looks like or it is the problem. So, and on AP, I see, well, that something bad happened to capitate. Let's say it like that way. So not only one cyst, but there are smaller one cyst and some sclerotic changes. So this is okay. What I would think about, what I would worry about, how the capitate is doing. This is the first one. And then I see next to capitate to hamate, there's also, well, we should assess it, but maybe there is also a cyst, what means there is another problem. Yeah.
Thank you,
you.
Tadeusz.
Yeah, just to add something. Sorry, hi everyone.
Hi,
First of all,
Lorenzo. How are you doing?
apologies.
Thank you, Lorenzo.
Yeah, very good. My apologies to it's my fault that we have a small amount of imaging at this point, because I had trouble to contact the patient, so that she sent us the pre-op X-rays and everything. So the only images, the only pre-op was the poor quality CT scan that we have. That otherwise, just to give you some details, the X-ray showed only a small loss of height between the capitate and the lunate, but no obvious lesion in the radiocarpal compartment of the wrist.
So the main problem is, if we summarize, the main problem is this kind of
Is midcarpal.
Yes, degenerative change in the midcarpal, especially between the capitate head and the lunate. Perfect.
Yeah, and the infection was really in the next weeks after the SL repair. It was a soon infection.
An acute infection post-op. Okay. And do you have any information about any chronic infection possibility, or did you wonder if the patient has some chronic infection?
We know she was treated with long-term antibiotics, and we did some new puncture of the joint that was sterile actually, and there was no argument for a recurrency of the infection.
Perfect.
At this stage.
Thank you. Bülent would like to say something.
Hello,
Bülent, how are you doing?
I'm fine, and you?
Nice to meet you.
You said that you operated because of the SL dissociation, is it?
Yes.
So yeah, she was operated for SL.
Now it seems okay. Which kind of operation you done?
As Logan presented in the first slide, it was a dynamic instability. So she had a Matulin-like dorsal repair, arthroscopic repair.
Only arthroscopic repair. It is very rare after the arthroscopic operation. Is there any other infection caused because of the patient?
Yes, we think so. It was actually a patient from Christophe, and she had a really, really early stage of STT arthritis that in the same time she had, in the same time of the operation, she had a steroid injection of the STT. So in my mind, probably this is what caused the infection, due to the combined STT steroid injection and the repair of the SL.
And another question, is the cyst seen before the SL repair or in the first operation?
No,
Did
no,
you?
that is new. That is, she had normal bony examination before the first surgery.
Okay, thank you.
Thank you. So Logan, I think you can go on with the presentation. We have a poll. I already
So we
shared
have
a
a
poll.
poll.
Yes, a poll of
At this point, knowing what we know, what treatment options would everyone consider?
So I already shared the poll for the attendees. Fabio, hello Fabio.
Hello, Halan.
How are you doing? Thank you for joining. Very
Thank you.
nice to see you.
At that point, I want to check the MRI because I need to know about the stage of cartilage. And if don't have a option to get MRI, probably I schedule to the surgery for arthroscopy, and in the arthroscopy check the mid-carpal and radiocarpal joint, and after these things I found in the arthroscopy, I decide if the mid-carpal joint is bad. One option is arthrodesis lunocapitate arthrodesis. The problem here is not easy to remove the scaphoid bone. We need to check or program how can remove, because this is the point in difficult in that surgery.
Because yes, so capitolunate fusion, if there is a problem, I can see Carlos, you would like to say something, or Paula? Hello, Carlos.
Hello. Nothing for the moment. Thank you.
Nothing for the moment. Paula?
Yeah.
Yeah, hello to
Hello.
everyone. As Dr. Tandoy just said, I'll try to check the survey of the bones, like the cartilage stage of every bone in the radiocarpal articulation and midcarpal, and with the MRI or with the scope and with that direct view of every bone. I think the survey of the lunocapitate articulation it's already a little bit narrowing and can be damaged. So I'll check the surface between the scaphoid and the capitate. And if it's lesion, I will try like a four corner arthrodesis.
Okay. So no conservative treatment for you. Thank you, Paula. And I see we have first Lucien and after Bülent would like to make a short comment, please. Lucien?
Yeah, I think the main problem, as seen in the CT scan, is like an impingement between the scaphoid and the capitate. And this is why we have those reabsorption cyst. And it's because of the infection that has consumed the cartilage in this place. And mostly we do bone fusions in advanced arthritis. Maybe in her case it will be too much. I would scope it, and maybe an interposition will be fine as a first operation. I wouldn't like to put her screws or plates after an infection, even if we know that it went off, because I think it's too risky now. For sure, I would evaluate the possibility to do something smaller in arthroscopy.
Okay, thank you. So a conservative treatment option for Lucien and Bülent, and after we can go on with the case. I think Bülent, please.
I want to learn the culture results in the first step. Did you solve the infection problem easily, or is it take long time? Because I think that it would be another infection after your operation. It could be. That's why, do you check the culture? What is the reason of the infection?
Lorenzo,
I mean,
maybe? Right.
it was an acute infection a few weeks after DSL repair. We treated in an acute way with the arthroscopic washout and 6 or 8 weeks antibiotics treatments. And then she had for more than a year had absolutely no clinical sign of infection recurrency. And we did some new MRI and also a CT arthrography, where the radiologist, before injecting any fluid, try to puncture, take some of the intracerebral fluid and examine it on the biological point of view. And we did know we'd had a sterile fluid, intracerebral fluid. So we had no clinical or biological or radiological for a new infection. So, but I agree, this is always something you have to be aware of. But we had very few arguments in that direction.
Thank
at this
you.
stage.
Right,
And
sorry.
unfortunately, we don't have the slides for it. And once again, I'm sorry for that. But the CT arthrography that she had, and also the MRI, showed only very correct cartilage on the radiocarpal surface, and only cartilage defect on the head of the capitate. That's it.
Thank you, Lorenzo. Thank you, Bülent. I understand Bülent's point of view, because if we want to be sure at 100%, we should take some bones and do some culture on the bones. But I think it is a problem, in my point of view, if we put some hardware. It would be the problem, as Lucian told us before. So I think, Logan, you can go on with the presentation.
All right,
And
so we didn't.
you can go back, please, because we asked to the to the therapeutic options. I shared a poll about the therapeutic option, and for our attendees today, we have the majority, 38%, for the interposition. Some people would do proximal row capectomy, only 13% of the attendees, capitolunate fusion for 25% of the attendees, and PRP injection for 25% of the attendees. So we have some people for conservative treatment and other for definitive treatment. So Logan, please, you can go on with the presentation.
The big reveal, we did an arthroscopic, what's called autocart grafting of the head of the capitate for the isolated midcarpal arthritis. So what is autocart? Because this is something that would be very new in hand and wrist surgery, since it hasn't ever been done in this smaller joint. So it's a surgical technique to treat symptomatic articular cartilage defects. And it's made by Arthrex. There's a surgeon in Chicago, US, who invented it, Dr. Brian, I think, Coleman. It's a single stage matrix augmented autologous chondrocyte transplantation. And so it combines articular cartilage using their trademarked GraftNet device, which helps you harvest the cartilage, and then using this biocartilage, which is another invention or device with Arthrex, as an extracellular matrix to create your graft. Right now it's used in larger joints, so hips, knees, ankles a bit smaller, but shoulder and elbow for articular defects. And it can be used for traumatic defects or degenerative defects. And really, it's an option to avoid or try to defer those larger joint salvage or total reconstruction procedures in patients who have more isolated defects or specific areas, as opposed to widespread, especially in large joint. And like I said, never previously used in hand or wrist. So what do you need to be able to do this? There's a number of components, and I don't mean for this to be like an Arthrex sales pitch. It's just, since it's new to probably all of us, we may not have seen some of these devices. So the first thing is this GraphNet attachment that will attach to the suction, your arthroscopic shaver suction. And the next is that you need this mixing and delivery system, which we'll show you a bit more afterwards, and the centrifuge, as well as a blood collection to generate to create the PRP in the centrifuge. And then there's their biocartilage, which gets mixed with this. So I have a video here. Let's see if I can get this going. Just talking about going through the steps of the procedure. So first, like I mentioned, we did the blood draw, and I got the PRP, got that going in the centrifuge, and then that was mixed with the biocartilage granules. I have some other pictures of that as well. We started with dry arthroscopy here, and so I just want to take a moment to show you exactly the amount of articular defect that we saw. So in a few moments, you'll be able to see the amount of damage that was on the, oh, I'm trying to pause it for you. Hold on. So here you can see the amount of articular defect there was. So it's quite extensive on the capitate. Oh no.
It's okay. We can see the video.
Sorry, a bit of trying to work with two screens here. And I'll just kind of narrate as we're going through this. So we started off with dry arthroscopy through the 3, 4, 4, 5 portals, and started off with debriding the capitate. And we used a combination of a curette plus a shaver to do this. So just introduce the curette right through the portals, just because then we could really scrape off the defect to create a smoother surface that would accept the graft. So that's what we're doing here.
As you can see, the state of the cartilage of the scaphoid lunate was not so bad opposite the head of the capitate. So that's why also we went forward with this technique. Otherwise, I think it wouldn't have been a good indication.
So now that the articular surface is completely clear, we went on to harvest the cartilage graft from the ulnar head. So we attached that GraphNet, which was the suction device, which I'll show you afterwards, was attached, and we started to go to the ulnar head and harvest some cartilage, which was sucked into the canister. So that's what we're doing here.
So yeah, the problem of this technique is that you need some graft from elsewhere. So in knees or shoulder, it's not that complicated because you have large joints with large cartilage surfaces that you don't need. In wrist, I question myself where would I want to take the cartilage, and I chose to take it from the tip of the ulnar head, just some kind of a wafer, just only for the cartilage, since it's a more or less useless cartilage. So I shaved it only from the tip of the ulnar head, and then mixed it with the rest of the recipe to create that paste that we will see in a few moments. You can also take a bit of cartilage around the lesion just to create some small, as you can see, some called debris of cartilage that will give you some chondrocytes afterwards.
So all the cartilage you take here is
yeah, it is sucked up by your shaver, and it goes inside your GraphNet with stop all the cartilage pieces, and then you retrieve them at the end into your fisherman's net, actually.
Mm-hmm.
And how do you know intraoperatively if you have enough cartilage according to the surface you need to graft? Do you have something, some landmark, something from the company? No. Did they tell you?
No, because they have some for the knees or else, but
yeah, okay,
not for the wrist.
Yeah.
So maybe I'm wondering if I can bring this a little bit forward here.
Yeah, maybe.
So it's important to
how
do
come
right.
you didn't take it from the helmet of the tip of the helmet, which
that was my plan B if I did not have any sufficient amount with the ulnar head. Actually, yes, I agree. But actually, it was okay with the tip of the ulnar head.
So here once we had all of our graph, we did our little mixing cocktail, which I'll show you in a moment. We needed to dry the articular surface just because we want to accept and hold on to that graft. And again, it's still dry arthroscopy. So all we did was essentially take a hemostat and have just a sponge attached to it and just kind of shoved it through the hole and tried to do our best to dry off that articular surface. That's what we're doing there. So here we are drying it off as much as we can. And then the paste is loaded into essentially like a trocar delivery device. And so here it is right here where it's coming out of that basically pipette onto the surface. And so Lorenzo, I mean, you can comment on this, but that's tricky because you're trying to take this paste and it's coming out in basically a ball and you're trying to flatten it. So
first of all, the instrumentation is dedicated for large articulations, or it's quite difficult to pass small amount to this. But the only difficulty is that since it's the head of the capitate, you have to work actually on the ceiling, and gravity is against you. So it's quite difficult to maintain it. But I mean, it's a bit tricky, but you can manage to do it, as you can see, piece by piece, and to pack a little bit that graft all around your defect.
Mm-hmm.
So it's a paste made of fragments of cartilage, actually, mixed with fibrin and PRP. And then, as you can see, we have like quite a good coverage of your defect. And then the last step, as Logan will show you, it's just to put your glue actually to hold it together.
So now the next step, you'll see that it's a bit hard to see, but you'll see a liquid coming through, and that's the fibrin glue. There you go. And you're just essentially sealing it off. And there you are. You have it. That's what it looks like at the very end. The fibrin glue. So here is a closer look at some of these steps. So this is the PRP that's being mixed with the granules. And then you have to shake it so it gets a good shake. And then I just wanted to show you this device. This is the graft net right here attached. And this is us Lorenzo taking the graft here. And then on this last picture, this is the essentially kind of trocar pipette, if you will, where we put the material from here with the cartilage in and made that paste and put it into here. So the one nice thing it seemed like, Lorenzo, was that it was a nice pipette so that you could direct it specifically to the region, although maybe still a little bit big for the wrist.
Yeah, it is. Yeah. They are thinking about developing a smaller one, actually, but.
So post-operatively, there was a K-wire placed across from the scaphoid to the capitate to maintain that position during healing. Bulky dressing with a fiberglass boulder splint for a week, and then into a thermoplastic for 5 weeks. Total, correct me if I was wrong, Lorenzo, but I believe we splinted for 6 weeks and then started with a hand therapy protocol.
So then if I just want to stop you right there for a few minutes, for a few seconds, they have larger experience in the knees and everything. They always tell you that the results come 6 months later. So you don't have to wait anything good before 6 months post-op. So now it's 4, maybe 5 months. So we'll see. But what we decided is when we removed the K-wire, we went back with the scope just to see how it was 6 weeks after, just to have an idea. So that's the post-op shot.
I think the proof is in the pudding. Looking at this looks pretty good.
I mean, it's not a normal capitate, of course, but consistency. I mean, the consistency of the cartilage was quite of the same of the, more or less normal cartilage, and we didn't have any subchondral bone exposure. So of course, then there will be some more remodeling after that because it takes 6 months to have like a flat surface approximately. But that was the 6 weeks aspect. So now we'll see. I have to see back the patient with an MRI in 1 month or 2. So for those who are interested, I'll let you know. But I mean, we decided to go with this because she's 20 and it was not a mid-carpal arthritis. It was actually an isolated defect of the head of the capitate. With, I think for me, it's a different treatment of a full mid-carpal arthritis with a scapholunate problem that was actually treated because there was no SL instability later on. So we'll see.
Thank you, Lorenzo. I think it is a very good option for this young patient, and it doesn't burn any bridge for another surgery after if there is any problem. I think you made a very, very good decision. Logan, could you conclude your case, please, if you have conclusion?
Yeah, just a couple technical tips. So when doing this technique, you really just want to cover about 70% of the lesion because you need to allow room for that graft to grow. And so with experiences using this in the knee, not myself, but with the company, they're saying that if you put too much, it's trying to grow and then it can become a large mechanical block. So being aware of that. Dry arthroscopy, obviously, to avoid dislodging the graft, and then you want to keep it concentrated and stuck to where you're meaning to treat. Drying the recipient, I think, is key as well. And then there's a lot of steps to preparation. So make sure you have a great team. It was even helpful having the reps available there too, because they can guide you through all of those steps, especially if you have a team that is likely unfamiliar with this procedure. There's a great video from Arthrex on if you want to see more. Thank you.
Thank you, Logan. Thank you, Lorenzo, for this great case. Very seducing. And I just have a question. If you have more defects, have you spoke with the company? Is there any limit in the grafting or the articular surface? Because we have many potential indications. It's very seducing. Lorenzo or Logan?
Well, I guess the limit is how much you can harvest elsewhere. Because, I mean, if you have a huge loss of cartilage, I mean, I don't think you can resurface the whole knee, for instance, because then you would need a lot of cartilage. In the wrist, I don't know. I think first we have to see if it works because maybe the MRI will be a disaster. I don't know. But once again, we didn't burn any bridges. But I don't know. I don't think there's a limit in the area that you treat. I think there's more a limit that the cartilage where you can harvest in the harvesting area. So
thank you.
Exactly.
We will see. You will show us maybe in the next symposium the results. Bülent, you have just before Logan, could you please stop sharing your screen so we can have everyone.
Thank you for your sharing this interesting case, and I use it in the knee, but it is a weight-bearing joint. That's why it doesn't work well. But perhaps in the hand it could be work. But in my hand, if I have a cartilage lesion in capitate, I try to make a medial femoral condyle flap. It could be because of the infection, I'm afraid relapse of the infection. Perhaps you could try to get a vascularized bone graft, bone flap, and it could be done a very well-shaped cartilage from the medial femoral condyle. And you could take a chondral tissue in the medial femoral condyle also. You could get much more big amount of cartilage in there. It's possible.
Okay, so vascularized bone graft, but it is an open procedure. Logan or Lorenzo, our patient here is a young patient that has all her range of motion. What do you think about? Do you have something to add to Bülent?
Yeah. I mean, she has actually had a good range of motion, so we wanted to preserve that actually and avoid any aggressive technique. And she also is very afraid of any surgery. This patient had trouble to convince her to treat her early, and so I think it would have been difficult in this particular case to convince her with a more aggressive surgery. But I agree for harvesting the cartilage in the knee. That was also my plan C. If there was any cartilage in the wrist in sufficient amount, I wondered that I might go with the shaver inside the knee to take some cartilage at this stage. But in this case, vascularized graft, I don't think she would have accepted. But theoretically, I agree. This was another elegant option, of course.
I have some problem of touching the knee actually in young patients when we don't have a guarantee of 100% of the results. So in this kind of young patient with all the range of motion, I would go crescendo with a less invasive technique for interposition, or that is why I find this technique very, very seducing. But it is a point of view, and maybe going to a more invasive technique secondary. Lucien, from Italy, please.
I think that the main issue is that she has no dysfunction of the wrist now. So the main problem is the cartilage defect, and that's why I think the technique is perfect for this kind of patient, because if the ligament weren't good, also it would have been more difficult to apply this kind of technique. But I think that in this kind of cases where you have a cartilage defect, it's perfect. It's quite perfect, and we see it also in patients that had fractures and have a little bit of pain in the radius because they have a cartilage defect in the radius. And PCO made a very nice article about cartilage grafting. So it's a less invasive technique to cure this kind of patient. I think it's a very nice application, Lorenzo, as always.
But Lucien, you talked about PCO paper. PCO paper was written, I think, more than 10 years ago.
Yeah.
Does anyone, because we don't have PCO today, you should have invited him. Does someone know why he stopped? Because we have just, I think, one paper with I think a very few number of patients for the technique we're talking about.
The thing is that he harvests from the knee cartilage.
Yes.
So this is the main problem. So one of the problems is we are wrist surgeons and hand surgeons. So we don't have not all of us are orthopedic surgeons, and so not all of us have the capacity to do a knee arthroscopy. And even if you're an orthopedic surgeon, maybe you are used to do from the residency meniscus, but harvesting a graft, it's a bigger surgery. So I think his technique was not so seducing, like you say, Alain, for us hand surgeons. And this technique is simple. It's much more simple for much more applicable for us, the hand surgeons.
Thank you, Lucien. Do we have any question from the chat, Lucien, or nothing? So we can very interesting case.
Paula Ramirez did the same question I did. She wanted to know if actually there was no other problem, only the cartilage joint, but I think that
it was an isolated.
already answered it. That's it.
Thank you, Logan. Just to conclude, because we need to go on with the next case, please.
I just had one, hopefully it can be a quick answer, but there was a lot of you who had said that you would do an interposition. So I was just curious what interposition you would do, because it's such a vague term, and there are just so many ways that you can consider doing it.
I would do it with a graft, with palmaris longus, or a piece of FCR.
There is something very seducing, once again. All this allografts, this tissues, these tissues that we can introduce. Pedro Delgado showed his series for radiocarpal arthritis at the fascia rimini, and I tried one. And actually, it's very thin. And I think if you have it in the OR, when we need to interpose something, even if we don't have the palmaris longus, is something very easy to interpose.
The tabotamp?
It is a dermoallograft. Yes, there is many companies that do things.
I used the tabotamp that normally neurosurgeons use to cover the brain, and it becomes like a jelly. And you can use it if you don't want to use.
The one we use is kind of acellular with color hand.
Or you can use also adipose graft from the abdomen, if you can have it. I have it. There are a lot of things that you can use, but
so conservative treatments are multiple. Bülent, please, the last comment, because we need to go on with the second case. Yes, very short comment.
I am wondering the long-term results. Please, if you have a possibility to show us for 1 year results, it's very appreciated. Thank you.
So September.
I will show you the.
You should scope her every year. And then
No, don't tell this in our symposium, please. So thank you, Logan. Thank you, Lorenzo. We will go on with the next case. We will go on with the next case. Our friend Magomed Dohov is now fellow in IWC Istanbul with Bülent. Please, could you share your screen and present your case? Stop for the therapeutic option, please. We can't hear you. Can you switch on your micro, please, Magomed? Hi, how are you doing?
Hi, okay.
Thank you.
Do you hear me?
Yes, we hear you. Thank you for joining, and you can start, please. Thank you.
Good afternoon, dear colleagues. It's an honor for me to be part of this conference. I would like to present a clinical case of post-traumatic instability of the first CMC joint. The surgery was performed in Istanbul International Research Center. The patient complained on the pain and instability in the thumb, difficulty grasping and holding. He got trauma 12 months ago as a result of his hand getting hit by the iron cable. On the same day, he was diagnosed with first CMC dislocation, and key wire fixation was done. During the examination, hypermobility and pain in the thumb were found. In these videos, you can see the degree of hypermobility in the first CMC joint in different directions. Please, what would you use for verification of the diagnosis in this case?
I think we can ask Master. We haven't heard you since the beginning. How are you doing?
Yes. Yeah, fine. So I will start with a simple investigation first, like X-ray and stress X-ray view, and after that, for MRI to see ligament injury. The two most important ligament for carpal metacarpal instability is deep anterooblique ligament and dorsal radial ligament. So I want to see if there is injury over this ligament or not.
Thank you, Martha. I think we all agree for the MRI as the imaging, pre-op imaging. Thank you. You can go on, Magomed, please.
In this slide, you can see how we have X-ray of the patient hand in different views. And this X-ray, you can see a lateral position of the first metacarpal bone. Additional, we done the CT scan. Here we can see results of CT scan and MRI confirm abnormal shifted position of the first in the first CMC joint. On this slide, CT images in sagittal and coronal views are presented. I'm sorry for the speed of the images.
Maybe you could comment because you know the MRI, Magomed.
On MRI, we saw that the same shifted position of the first metacarpal bone in the CMC joint and safe of the cartilage lay of the in the joint. Which kind of treatment do you prefer in this clinical case?
I shared already the polls for the attendees, and does anyone would like to share his opinion about this CMC instability? Maybe Fabio.
Hello. In this case, I need to know how is the cartilage, because depending on the cartilage, I can offer some solution. I have a technique in acute case. This is different, but we apply for this case, I believe. Capsuloplasty, biarthroscopy. Please check the biarthroscopy, the stage of the dorsal ligaments. Check with hook, and after the check with hook, I can repair or reattach the dorsal ligaments, the complex dorsal ligaments. In this case, I need to know the cartilage. I prefer check by arthroscopy because this is best than MRI, and then check the state of the cartilage, decide if I can repair or repair the dorsal complex ligament by suture anchor in the dorsal side. But if the cartilage is bad, we can do probably other option, probably trapeziectomy and tendon interposition is the cartilage is bad.
Some conservative treatment. Fabio, would you apply your technique of the acute cases? If the cartilage is good here, would you apply your technique for the acute cases here for the chronic in the chronic situation?
Yes,
is it possible?
But if the cartilage is good, and the ligaments lost the tension, I believe is important to reattach these ligaments, and it's a good solution. And check obviously after they try to repair this ligament.
Thank you, Fabio. Lucian, do we have anything for from the chat or some question for the moment? No.
No, for the moment, no. I want to make a comment for the assessment, the diagnostic assessment. I think that in these cases, an X-ray and an ultrasound dynamic check is very important during the visit. It maybe gives you more information than the MRI, and then I would go to arthroscopy directly, because you need to find out what is the cartilage situation and how are the ligaments.
Do you think the ultrasound, the dynamic ultrasound, is enough precise in this case to check the status of the ligaments? Because the MRI can show us the the status of the ligaments, but the ultrasound, no. What do you think, Lucian, about this?
I think that you can, if you know the anatomy of the ligaments, you can see their detachment, trying to look, say, the articulation. So you can see it. You can go to the various group of ligaments. We know that we have 3 groups of ligaments that are important in this kind of joint, and I think that you can observe which group is not really attached.
But finally, sorry.
Yeah. Tell me.
But finally, the arthroscopy seems to be the best assessment option. Yeah, the more accurate.
Absolutely. And I think that the Fabio technique that I tried is very intelligent in these cases, but we will see.
And we asked Fabio to share his technique for next symposium, maybe. Magomed, could you go on with your case, please?
Yes, of course. Arthroscopic CMC debridement and ligamentoplasty via tightrope was performed in this case. The first stage of the surgery, arthroscopic debridement of the CMC joint, was done. During the arthroscopic revision of the joint, condition of the ligaments and cartilage was checked. Then rest of injured ligaments were removed. Sorry. Special attention was paid to debridement of the ulnar side of the first metacarpal bone basis.
Could you please, Magomed, comment what you are debriding exactly for our attendees here on the video?
We try to debride the medial side to refresh the ligamentous structure. It is very important because we need biological healing after the treatment. That's why we have to debride the medial side, especially along the metacarpal head, and we try to make a new refreshing tissue in the CMC joint.
Thank you.
At the next stage of the surgery, we put 1 millimeter Q wire with the loop in the end through the basis of the first metacarpal bone to the second metacarpal bone. It's very important to locate Q wire in the second metacarpal bone in the correct position. It should be on the border between proximal metaphysis and diaphysis of the second metacarpal. These steps must be done under X-ray supervision. This Q wire is the guide for the tight rope, which is put through the bones with the help of the loop in the end of the Q wire. The first button should be located on the surface of this first metacarpal bone basis. Then the second button goes to the end of the rope and is located on the ulnar surface of the second metacarpal bone. It's very important to prevent the interposition of soft tissues between the bone and the button. After the placement of the button, the rope is tightened. Appearance, the white space in the first CMC joint on the X-ray indicates enough tension of the rope. The patient after surgery doesn't need any immobilization. On this slide, you can see the degree of stability of the CMC immediately after surgery. This slide demonstrates the range of active motions of the thumb on the first postoperative day. There are 6 similar cases with no complication and good outcomes. This type of surgery is recommended for young patients with instability of the first CMC joint and the safe cartilage coverage of the articular surfaces. Thank you for your time. Please, questions.
Thank you, Magomed. Do you hear me? Because I'm sorry, I think I have some technical problem here in my computer. Everyone hears me?
Yes, hear you.
Okay. So okay, so anyone has any comments? Could you stop sharing the screen, please, Magomed?
I have a question, Madam.
Yes, Carlos, we hear you.
It looked this technique more than a suspension plastic, more than a ligamentoplasty. So I am a little concerned about the stability in the posterior outcomes, I don't know, in 1 year, 2 years, I am not that sure that the stability of this technique will be that good. Can you hear me?
Yes, we hear.
May I answer?
Yeah.
Bülent, we hear you, Bülent.
Yes. Matudan always said that we put plate and we wait for the biological healing. In the first step, I said that I try to make a debridement in the medial side to get a new ligamentous healing. That's why we make an internal fixation and we wait for the biological healing. That's not ligamentoplasty. We don't make it to make a ligamentoplasty. It works like a fixation material.
Thank you. Thank you.
Thank you. We have Logan and Fabio.
Thank you so much. I loved seeing the video of the procedure. I thought that was great. So question for you was, is there any patients you would consider not doing this on? And the reason I'm asking is because I have a very, very active gentleman in my clinic who I actually just saw recently, but he does a lot of biking. And so my concern with that is that he has his hands around the handlebar a lot. And so his thumb is in a lot of abduction and there's a lot of pressure there. So I worry, is he more at risk that this could rupture or there'd be a failure in this technique? What do you think?
Magomed, I am sorry. I want to answer these questions. It is for the long time. We published for the arthrosis. We make a suspension plasty and we know the results before this case. We have over 100 cases in ligamentoplasty with tightrope. The main problem for the adduction, you have to put it very proximal in the second metacarpal. Because you make you are right. The abduction restriction could be happen, but if you put it proximally, and it's a small amount of abduction restriction, but generally people hasn't got any complaint about the abduction. The other things you have to put in the proximal as much as you can, because the strength of the tightrope could be fractured, and we have two fracture in this case, second metacarpal fracture. It is the worst complication of our clinic, and you do something for the CMC joint and you have a fracture in the second metacarpal. It is not acceptable. And the other things, the patient could use their hand in the second day of the operation. You don't need to fix, and you don't need to make a cast or another things. And the patient is very happy to get their hand earlier, and because of that, the early motion, the restriction of the motion is very limited, and I thought that it is easy. It takes a half an hour, and you are sure that you have stabilized the CMC joint, and in acute cases it could be used, but in the long term, the patient, the tightrope has got some loosening. That's why the patient get more abduction, and the long term, we haven't got any problem in the abduction. Thank you.
Thank you, Bülent, for this comment. Before I would like to share the polls results. 14% would go in this case for CMC1 arthrodesis fusion, 43% for ligamentoplasty, 29% for trapeziectomy and suspensoplasty, and 14 patients for trapeziectomy and interposition. Thank you for answering the polls. We have first Fabio and after Lorenzo, who would like to make a comment, I think. Fabio?
Haran, I believe in this case, I will apply my technique because when I check the video, I can see the injury of the ligament of from the metacarpal area. And I believe if I can put a suture anchor in the metacarpal, we reattach the ligament.
Thank you, Fabio. Could you please, I ask you for next symposium, if you can, if it is possible for you, just to prepare a very short video of your technique? It would be great.
I present this technique in October in Italy, in the National Congress. We can present. Thank you.
Thank you, Fabio. Lorenzo, last comments, please. We don't hear you. Switch on your up.
All right, sorry. Yes, I just wanted to give a few comments more on what just Bülent said, because I think it's a good technique. I use it to treat most of my CMC thumb arthritis also, with an arthroscopic partial resection and then stabilization between the first and second metacarpal. And one very important trick to do it, whether it's for arthritis or in that case for a ligamentoplasty for instability, is that, as Bülent said, you put your implant as proximal as you can because there is a fracture. But if you put it proximal, be careful to fix your implant in a first web opening, otherwise you restrict the opening of the first web. And the second very important trick is that when you tie your implant, when you do your second knot to apply it, if you tie too much, in some patients, you have a risk of creating an impingement between the base of the first and the base of the second metacarpal. So I usually put a small mosquito between the two, tie as much as I can, and then release the mosquito, and then you have a small loosening of between the two, a small space creating between the first and second metacarpal. Because otherwise, in my first patient, I didn't do this trick, and I have two patients with pain between the first and second metacarpal due to this impingement. So that's something also you should be aware of when doing this technique. But I think I agree with Bülent. It's a nice technique. It's quite simple to do. It's quite quick, and it works fine with long-term results also.
Thank you, Lorenzo. Thank you, Bülent. I have just a comment. I don't use this implant. Bülent, maybe you will answer, because I have really some concern about the complications we heard about and some necrosis even of the skin. And I have really concern, even if it's one between 100 of cases. Could you tell me to reassure me and to go with this technique, please, Bülent?
And
Lorenzo,
you have to be sure that the button is on the metacarp, and you have to open the soft tissue over the metacarp, and you have to get sure with scopy to be in the metacarpal base in the first and the second metacarp. And but the main trick is the radial superficial nerve has a branch on over the first metacarpal base, and you have to protect the nerve. If not, you will have a pain on it, and the patient has got a lot of complaint because of the nerve compression. And the second trick is you have to I do the same thing like Lorenzo. I make some loose tightening in chronic cases, but for acute cases, I prefer to make it make it tight as much as I can, because I need some ligamentous healing in the medial side. That's problem. I want to make it as near closest to first and second. The other things, you have to be sure that the button not apparable in the skin. It could be in the middle of the second metacarp, and that in that case the second metacarp, and you have to cover it with soft tissue. And in this case, you haven't got any problem with a button. And it is, I think that if you put it exactly true position, you won't have any problem with this technique.
Thank you, Bülent, for the advice. Thank you for presenting this case. Now, I think, do you hear me?
Yes.
Because I'm sorry, I think I have some technical issue. So, Fabio, you want to just the last comment, short for this? You want to say something? No, it is okay.
Oh, no.
Well,
Thank you.
actually, I have a question. Z here. I'm not sure why my name is
Hello,
Gaurav.
Z.
Okay, so I just want to ask Dr. Bülent, what do you do when you had the second metacarpal fracture? In this case, what was your next step? Because it can happen. And number two is that I assume that this is an acute case, if I'm not mistaken. And I want to question the role of arthroscopy in this case, because do you do a thermal shrinkage in this case to try to tighten the capsule at the same time before you do a tightrope? Because technically you could have just done the tightrope immediately without an arthroscopy.
Yes, first step I said that I make a attention about that. We have to debride the medial side of the metacarp, and we have to refresh, because we want to get the ligamentous healing. That's the arthroscopic advantage. You haven't got any other options to get refreshing in the medial side. And the second question is a very important point of this technique. And when I have a fracture after, one of them is after 6 months, the other one is after 1 year. And I am sorry for that, but they have a osteoporosis. That's why after then I afraid of the make this kind of operation in osteoporotic patients. Be careful. And the other things that I remove the tightrope, and I saw that the instability healed, and the patient hasn't got any problem in the after the removal of the tightrope. The ligamentous healing coming with this technique, and I put a plate. After then I saw everything, but one of them has got infection, and I have got a lot of problem with infection. After then she has got another trauma, and she broke his proximal phalanx, and I have a lot of problem with this patient, but it is not a good time for me.
Thank you, Bülent, for your comment.
What do you say to your daddy?
Please, Paula, if you have a question, very short question, because we have to move to the conclusion, please.
Yeah, I don't think
A very short question and very short answer, please.
I don't think if I understand well, Dr. Boulan, you take out the tyro in all these patients after a few months? Because I don't get it, because I think maybe it's too much. Because if you do a ligament repair by arthroscopy or open, you just can leave an orthosis and then remove the orthosis. I think it's more easy and less invasive than check your repair with another surgery. You get it?
I have to remove the tightrope because the plate screw has got damage on the tightrope because of the drilling. I have to put a metacarpal plate. That's not easy to put without removal. That's why I have to remove it. And I am sure that the ligamentous healing coming with the time, and the patient hasn't got any problem in the CMC joint. Believe me.
Thank you, Bülent. Now, if you don't mind, thank you for the cases. Thank you for the presentation. It was very, very good for the two cases, very seducing techniques, conservative techniques. If you have time, we are just going to do a quiz about two cases. If the panelists could answer just in one sentence, what would be their therapeutic option? If you can see my my screen, we are not going to be very long. We have first case of a female, 55 years old, that had a very complex articular distal radius fracture 1.5 months ago, and this patient came to the clinic, to the consultation this week. She's right-handed executive assistant, and she had elsewhere this kind of treatment 1.5 months ago. So she had some mid-CRPS syndrome symptoms here. She has a disabling and continuous pain. I'm sorry, she came only with this imaging. And I would like just to do a very quick, fast quiz to our panelists to ask what would be the immediate therapeutic option, the decision, because this patient has inflammatory symptoms. Should we let her like this? Do you have any experience with this kind of treatment? I haven't seen this before. And or should we go for an osteotomy and operate her? Lucian, Laurent, yes, what would you do here in 1 September?
I will take off the pins, do an osteotomy. Before I would do a CT scan, I would do an osteotomy, and I will also do a neurolysis of the median nerve. And I think it will be the best treatment for her. I have some cases like this.
Yeah.
And there are still orthopedic surgeons that treat that way this fracture.
Difficult. Oh, sorry. Thank you, Lucian. So you take off the hardware. You go to an Someone could please switch off the micro. Yes. Thank you. And so it is a difficult decision to make because the patient has some inflammatory symptoms now. So we are concerned. I have some concern about increasing the inflammatory symptoms. So you would operate her, Lucian?
Yeah, I would operate her. I think that Paco del Pinal also showed us with a lot of cases that the inflammatory or the SUDEC in these cases has a reason, and the reason is the not good stabilization of the bone. We should restore anatomy, and we should take off the scar tissue around the nerve.
Okay.
This is my point of view.
Thank you. Carlos or Fabio or Lorenzo? Carlos, what would you do here in one sentence, please? This is a
Yeah,
quiz.
totally agree with Lucian, but I will wait till the dystrophy get better a little more.
So no surgery for you now?
Yeah.
You are agreed. Okay. Fabio, what would you, thank you, Carlos. Fabio, what would you do here?
I try to reduce the radiodistal fracture.
Yeah.
Osteotomy, intraarticular osteotomy. I follow the guy or the manager of Dr. Piñal. But I want to ask Lucian about how do you do first arthroscopy or first open the approach to the radial and then start to do the arthroscopy?
I think that you need to do also arthroscopy. In this case, I think the problem is articular. You need to find out all the problems, the articular problems, and fix them. But you cannot do too many steps here in too many surgeries. You need to correct everything with one step because the post-op will be long in this patient.
Thank you. Anyone would be don't agree with this therapeutic option? Anyone would wait and for 2-3 months? Bülent, do you have an experience with this kind of pins? I've never seen this before.
You have to remove the key wire first of all. After that, wait for the complaint, and after that you will see what happened.
That would be your your therapeutic option. That is what. Yes.
I don't want to make acute activity. It is not easy to do in here in this step, I think.
So no immediate treatment for Bülent. Yes. Zé, do you have what would you do here?
Yeah, I think I totally agree with Dr. Bülent. I mean, the reason why this patient has pain is probably because of the pin. So removing the pin, yes, but I would probably give the patient low expectation that she's going to have a super anatomical reduction and all that. But remove implant first, see how it goes. If it's collapsing intra-op and so on, then I might consider a spanning plate, and that's about it.
Sorry, but you are not helping me, everyone, because
I will respond, Jean. I will give the patient high expectation and do everything in the same way. And if you want, in the webinar, I will show some cases that I did in this kind of patients. It's a complex surgery, no problem, but it's possible.
So thank you, everyone. So half of people for immediate treatment with releasing carpal tunnel osteotomy and plating. The other half for waiting. So next quiz, just if you have time, male, 58 years old, right-handed manual worker. He have a complex left distal radius fracture 2 years ago. I am sorry, I have only this X-ray. And he came to me to the consultation. He has conserved range of motion, pain in all the wrist compartments. And as you can see, there is a huge radiocarpal arthritis, but the range of motion are conserved. So in one sentence, please, if you could answer, what would be your preferred therapeutic option? It's not a long case presentation. Lorenzo, would you do technique with the graphs here? Would you go? What would you do, Lorenzo? Are you with us?
I mean, I'm not sure I would go with the graft. I mean, he's 58. He's a manual worker, so I would have to prefer a strong and definitive option. So maybe, I mean, it depends on what he wants. If you want to preserve at all costs his range of motion, that would be discussed to do some kind of interposition or so. But otherwise, if it's a radiocarpal arthritis.
So interposition, because he would like to conserve his range of motion. He has all range of motion that are conserved, and the pain is the main complaint. He would like to go on with his actual current job. So I was I was sorry. I proposed to him the Delgado technique with the interposition with the dermo allograft here. Something very simple. Go with the arthroscopy. Anyone would have another treatment option, Lorenzo or Lucien?
I mean,
I would go with
if he wants that, I would start.
more aggressive solution here, because he's a manual worker. I would go with the radiocarpal fusion, arthroscopic. I think he will have good range of motion because the mid-carpal is free, and he will have a strong wrist.
Okay.
Arthroscopic with radiocarpal fusion.
Radioscapholunate fusion is usually well tolerated by patients, and especially in hard workers. So I would agree.
Bulent, thank you. So you do definitive treatment, Lucien and Lorenzo. Bulent?
And I haven't had a lot of experience, any experience, but I saw 2 times much less ligament interposition. And he said that it works, and I saw the last week with Ahram, and I think that it would be work in this kind of cases. It could be done with arthroscopic way, and he make a styloidectomy, put a anchor, and make a interposition arthroplasty like a sling in the radiocarpal area, and it could be work.
So first, for Bulent, thank you, Bulent. First step of ligamentous interposition, and we will see later. And thank you, Fabio. What would you do here? I think Fabio, he left.
Yes, I am here.
It's difficult. It's a difficult decision for this patient. Conservative, or you go to radioscapholunate. Sorry.
Radioscapholunate is a good option.
Okay.
I believe.
So, Bulent, I think we are the minority to think we should do an interposition here. Thank you. And the last case, and after we say goodbye, for the last case is a case of ligamentoplasty failure. And there is a problem for, I have some problem to solve this case. The 43 years old patient, manual worker as well. He had a treatment 1 year ago for acute scapholunate instability. And elsewhere, he had what we call Berger ligamentoplasty, open ligamentoplasty. That was the X-rays. And he came to the consultation this week, and he's not very happy because he had this result 1 year after. And he is asking, so the main complaints are the pain, the loss of strength, the decreased range of motion, as we can see here. And on the imaging, we don't see too much sign of arthritis. And she came to the consultation to ask for a solution for his wrist, to improve his wrist. And it is very difficult when you have an open treatment to propose to the patient something to go back, because for me, open treatment, we burn all the bridges. So what would you do? Nothing. Palliative treatment, conservative treatment. Do you have any ideas, Bulent? I have Bulent after Lorenzo, after Lucien.
I think that the first step in acute cases, smiley technique works well, and for the comment.
Yes, I agree.
It is easy, and in this step, I try to make arthroscopic debridement and make a capsular detachment or air and capsulectomy with wafer, and it could be open. I have a lot of cases who has got wrist restriction, and I do arthroscopic debridement, capsulectomy, and it works.
So debridement, arthrolysis, and arthroscopy, something very simple for you, Bülent. That is, if I.
Yes, it's true.
Thank you. After Lauren, thank you, Bülent. That is what I propose to the patient, actually, just to go for an arthroscopy, to do a kind of arthrolysis, because and try to see what will happen after. Lorenzo, what would you do? You have a beautiful idea for us?
No, I was saying the same thing. I think instability is not so much the problem here. It's probably with this kind of stiffness, it's not unstable anymore. The X-ray shows good position of the bone, no significant disease or else. So I think the main problem is stiffness of the joint. So I would go arthroscopic release of the joint, roller, dorsal arthrolysis, everything, and then physical therapy in first.
Thank you. Even if we know I have some concerns. The patient was operated open, and you know the Berger ligamentoplasty. You open everything. You cut all the extrinsic ligaments. So I have some concerns about entering in the joint. I hope I'm not going to break all our scuffs in the OR. Lorenzo, you will not be very happy. Lucien, please, what would you do?
I want to make only a notice, because he has a lot of pain.
Yes, in order.
So, normally, stiff people with that made a scapholonate reconstruction or capsuloplasty don't have pain. They complain that they don't move a lot, and they suffer from the non-movement. So if he has pain, I would also do an arthroscopic arthrolysis, but I will do also a selective denervation, because I want him to move a lot after operation. And if he has still pain, it will be not good for the outcome of the arthrolysis. So I would do also a selective denervation.
Thank you, Lucien. I totally agree. When I did the clinical assessment, he has a pain, but normally he shouldn't have. And I think it is because there is some sequela of a CRPS in the first place. Because normally he shouldn't have a pain, only a loss of range of motion. Thank you, everyone, for helping me with your ideas. So thank you for joining the symposium. Next one is in one month. Thank you for the presenters, Magomed, Logan, Bülent, Lorenzo, Lucien, everyone, and see you in 1 month. So have a nice weekend. Bye bye.
Thanks everyone. Bye bye.
Goodbye, everybody. Have a nice
weekend. Thank you for joining. Bye.